Thanks to the entire organizing team for inviting me. I will give a brief overview of two abstracts. These were late-breaking abstracts. One was in ASCO GU session last year, and another was in ESMO last year. And the first abstract was CheckMate67T, and this was regarding subcutaneous nivolumab administration. Because of the recent advances in medical oncology, we witness even stage 4 solid tumor patients are surviving for a longer period. So that's why quality of life issues are becoming very pertinent, and uh, uh, subcutaneous dose, it can make actually reduce the frequent hospital visits as well as frequent hospital admission. So this is becoming more popular, and this is not only true for renal cell carcinoma, it is happening across all the tumors like breast also. So subcutaneous nivolumab versus intravenous nivolumab in patients with previously treated advanced or metastatic clear renal cell carcinoma, pharmacokinetics, PK, efficacy, and safety results from CheckMate67T. So this was a open label phase 3 study. This study evaluated PK and objective response rate, non-inferiority of Nivo subcutaneous versus IV in patients with locally advanced or metastatic RCC who were previously treated. Patients who are advanced RCC patients who either progressed during therapy or after 1 or 2 prior systemic regimens. Patients were immunotherapy naive patients. So patients who are randomized to 2 arms. One is nivolumab subcutaneous dose, that was 1200 mg dose combined with recombinant human hyaluronidase injection to reduce the local site swelling. And the standard arm nivolumab IV dose was standard. And both the treatments were continued till disease progression, unacceptable toxicity, or completion of at least 2 years. So the endpoints, co-primary PK endpoints, there were 2 endpoints. One was time averaged serum concentration over the first 28 days. And the second PK endpoint was minimum serum concentration at steady state level. Secondary endpoint, one very important secondary endpoint was objective response rate, and other secondary objectives, there were other secondary objectives as well. So coming to result, total 495 patients were randomized. The average injection time for nivolumab subcutaneous injection was 5 minutes only. So this study was positive because non-inferiority of the co-primary PK and key powered secondary objective response rate, both all the endpoints were met. The nivolumab subcutaneous local injection site reaction was only 8.1%, and these reactions were low grade and transient. And this is a tabular form of results. As you can see, the objective response rate was 24% in subcutaneous dose versus 18.2% in nivolumab IV. Median PFS was 7.23 months for nivolumab subcutaneous, numerically superior from Nivo IV, which was 5.65 months. Regarding the adverse events, they were pretty similar. Rather numerically, the treatment-related adverse events were actually less frequent in nivolumab subcutaneous. So as medical oncologists, we can dream era where patients will take nivolumab just like insulin subcutaneous injection. The core primary, so this was a positive trial, and Nivo subcutaneous as a new option to improve healthcare efficiency. Now my second abstract, which is LITESPARK-005. It is Belzutifan versus Everolimus in highly pretreated clear cell renal cell carcinoma patients. We all know that hypoxia inducible factor, HIF pathway, is central to pathophysiology of clear cell RCC and von Hippel-Lindau disease. So belzutifan is actually first in class oral HIF-2A inhibitor. It blocks the heterodimerization of HIF-2A and HIF-2B, 1B, and that's how it blocks the downstream signaling pathway. And it is approved in United States for certain VHL disease like RCC or pancreatic neuroendocrine tumor and central nervous system hemangioendotheliomas, hemangioblastomas. This drug has demonstrated clinical activity in previously treated advanced clear cell renal cell carcinoma. This is a mechanism of action of belzutifan. It is actually HIF-2A blocker, and it blocks the heterodimerization with the other molecule HIF-1B, and actually then blocking the downstream signaling pathway. So coming to the study design, the key eligibility criteria was advanced metastatic RCC patients. Patients were exposed to both IO as well as TKI. So they are resistant to both IO and TKI, and they progressed after 1 to 3 prior systemic therapies. They were randomized to either belzutifan 120 mg orally daily or everolimus 10 mg orally daily. One may argue here that single agent everolimus may be an inferior comparator, but to note that these and if you see the baseline characteristics, just like any other IO trials of RCC, favorable number risk patients were very low, 12%, but that is the usual scenario across the all IO trials of RCC. The strength of this trial was that prior VEGF TKI was received by 50% of the patient, and rest 50% patient, they got at least 2 prior TKI. And prior 45% of the patients actually they received prior 3 lines of therapy. Such was the poor risk patients, they were enrolled in this trial. So coming to the result, PFS at 18 months, the PFS percentage was 22% versus 9%, favoring beltuzumab. Here, this is the subgroup analysis, and this benefit is evident in all the subgroups, whether they are IMD in all the subgroup, though it is not statistically significant because of it was not powered like that. And the prior lines of therapy, prior 1 line of therapy was there. That means if this drug is used in 2nd line therapy, then the benefit was maximum. OS was same. Numerically, there was slight difference, but it was not statistically significant. Regarding objective response rate, belzutifan has remarkable overall objective response rate, 22.7% versus only 3% with everolimus, and we all expect that with everolimus single agent. And not only that, though the time to response was pretty same, close to 3.8 to 3.7 months, but the median duration of response was longer for belzutifan. It's 19.5 months versus 13.7. Patients having grade 3 or worse anemia in belzutifan arm. And however, even we all know that everolimus is not an easy drug to use, and that's why if you see the discontinuation rate, that was higher in everolimus arm, which is 14.7% versus 5.9% in belzutifan arm. So to conclude this abstract, this trial establishes HIF-2A inhibitor belzutifan as a novel therapeutic mechanism of action in advanced clear cell renal cell carcinoma. Belzutifan demonstrated statistically significant PFS and objective response rate versus everolimus. Overall survival rates were same, statistically not insignificant, but the final analysis is pending, and belzutifan was well tolerated as well. The strength that currently it is being studied in combination in 2nd line, 1st line, and adjuvant setting as well. And to note here that LITESPARK-005 is the first positive phase 3 trial in patients who actually progressed after an IO and after an TKI, both these therapies. So this I want to conclude here. Thank you.